Hello, my name is Paul Friedman. I'm chair of the Department of Cardiovascular Medicine, and I'm delighted to be speaking today with Dr. Mauricio Villavicencio, who's an associate professor of surgery and a leader in heart transplantation. And today we're going to talk about ex vivo heart perfusion. So Dr. Villavicencio, welcome.
Well, thanks very much for having me and to speak about this kind of hot topic of ex vivo heart perfusion and transplant.
Hot topic seems like an appropriate description for this particular therapy. So why don't we start with the basics? What is ex vivo perfusion?
Well, I think to understand it a little bit better, we have to go a little bit back on how we have done heart transplantation for the last 30 years, since the pioneers of heart transplantation. And we have done it, going to a brain dead donor in which the heart is beating. And we have taken that heart and give essentially a cold flush with solution and put it in a cooler, essentially. And that has given us around 4 hours most of the time to perform the transplant, which obviously has some, logistical limitations and distance, and that for more complex operations problems. But that has been pretty much the success of the heart transplant, doing it this way with cold storage, as we can say.
So the basic idea with cold storage is cool the heart down, limit its metabolic activity, to limit ischemia so that it can safely travel before it's reimplanted. That's sort of the fundamental, and that's what's being upended with this new intervention.
Yes, that is correct. And then we have tried to struggle to stretch it a little bit in that way, but it's not really that safe, to stretch the time that can be out. So it's cold, it's immobile, it's not working. So it is, prolongs the time. And then if all organ transplant is the one that tolerates less time, so compared to the lung, the liver, the kidney, you could preserve a heart for a way less time than other organs. So it's a handicap of the cold storage.
Got it. So what are the major advantages then of ex vivo heart perfusion, and how does it work? What is it?
So ex vivo heart perfusion is, you can take, again, for that brain dead heart beating donor. We will talk a little bit later about the non-heart beating donor. And you take it from that heart beating donor, and then you hook the heart to a device. This device, the one that's FDA approved, is called the OCS heart device. And then essentially what it does is that pumps blood into the aorta. So the aorta is hooked to a cannula. So the blood goes in a pressure that normally is kind of normal pressure, 60 blood pressure, and perfuses the coronaries and then comes back through the coronary sinus. And then what you have to do surgically is close the inferior vena cava and the superior vena cava, and then to let that heart go and go through the right ventricle, the pulmonary artery, and then we capture it in a cannula that is on the pulmonary artery. And then there's a little bit of blood that is spilled over that goes through a receptacle that again is collected again. So we got the venous blood connected through the pulmonary artery and from some that is coming down from the reservoir. And that goes, it's very similar to an ECMO concept. So in terms that then goes through a pump, then it goes through an oxygenator, and then gets pumped into the heart again. So so that is the concept. Ex vivo heart perfusion, and the one we use now in the clinical setting is one that is mobile. So you could, take the device, transport in an airplane or in an ambulance, and then you perfuse the heart at normothermic temperature. So you bring up the temperature up to 36 degrees to do the perfusion. So in that you can get around, it's not clear how far can you go, but most of the people who have done total out of the body time of around 8 hours or even more. So that's the beauty of it.
That's really remarkable. Now, is this being done for lungs or other organs as well, or just for the heart at this stage?
Yes, it's done for the lungs. That my other expertise is lung transplant, but I think the benefits in the heart side are are more than on the lung side. And the reason for that is that you could do cold storage in the lung side for easily 10, 11, 12 hours, which we don't have on the heart. So on the heart is more critical. There are certain situations in the lung that can, be useful. For example, the DCD donors. We could talk a little bit more about what are the DCD donors. But in general, I see on the heart side to be more useful.
Tell me a little bit about the role of this technology in heart-liver transplants and how it could be helpful.
Well, because the history, heart liver transplant have been a very high risk operation. Most of the patients that have Fontans have multiple sternotomies previously, and that they are very sick, and then they are sensitized, so they have antibodies against human tissue. So I think one of the great advantages of having the OCS device that we are doing heart liver transplant, but with the liver first. So we do the liver first, which is an easier operation. It says that doesn't have, there's no previous operations, and then so you do the liver transplant, and then the heart has been out 6 or 7 hours, and then you go and do the heart transplant, and then has the beauty later on that. When you come off the heart and lung bypass machine, there's less vasoplegia because the liver is already in, and then there's less coagulopathy. So the liver is working, and then so the patients bleed less. So that's quite a bit an advantage. And there's a third very important advantage, that in these patients that are sensitized, if you do the liver first and you do some pre-treatment, with medication, the liver can take off, the antibodies against HLA antigens. So you could use it, to treat very highly sensitized patients in a, liver heart transplant, liver first. So it's very exciting technology.
Oh, amazing, really. And the time interval between the liver transplant and the heart transplant is usually how long?
Well, it's almost nothing, because what happens is when you do the liver implant, and then you do the reperfusion, when you do the reperfusion of the liver, there's quite a bit of hemodynamic instability. So what happens is then when you have instability, you have to go on bypass.
I see. So it's like one right after the other.
One right after the other, but it's important in terms that, it manages the antibody. So we're always worried about, hyperacute rejection with the antibody. So having the liver first, give us, peace of mind. We have published this, Dr. Daly lead the way on this.
How can you tell if a heart that's placed in ex vivo perfusion is a good heart?
Well, first, I'm a surgeon, so I'm a little bit like a, plumber, if you would say. So I like to see that heart beating strongly, directly in there.
Yes.
You could see there. So whatever something looks weak in there, I get nervous. So that's more sort of the macroscopic standpoint that you could see how the heart is looking like. But then what it has been studied in the clinical trials on the OCS device is the lactate. So the heart has this unique capability that can metabolize the lactate. And then so if the heart is working fine, instead of, producing lactate because it's ischemic or damaged, then start metabolizing the lactate. So the lactate that is produced by the heart during the perfusion on the OCS device should, most of the time depends on the type of donor, but most of the time will at least have to get stable or start coming down. So if a lactate starts coming down, then you would think that heart is working, and then that you want to use it. And then I think that is important because you perfuse this heart very long, or sometimes on the OCS device. So what happens is, for a reason that we completely do not understand, the heart gets edematous. So you have to examine the heart before implanted to make sure, that it hasn't gotten that much edematous. So it's still a little bit limited in the time that you could use. Because we would like to do an elective heart transplant if you would like. will be way better for the team. But so far with the management that we have, how we know the technology has not allowed us this yet. So that is the lactate, how you look at it, and whether or not it has gotten edematose. And then you have to also, do an integration, how sick is your patient, just to move forward with the transplant or no, or you can wait.
Now, for our listeners who maybe have never seen a device, I know we'll have a link available where they can watch a video, but just for now, how big is the device? And is it battery powered, or do you have to keep it plugged in? Is it on wheels? Give us a picture of what the actual device is like that the heart is in.
Yeah, so the device would be like the size probably of a dishwasher machine or something like that. And then it will have wheels that you could get it around. And then it has an area where it goes the disposable, where the heart goes. So it's a device, and you can monitor over the hematocrit, the saturation of the blood. You could monitor the blood pressure. It has a monitor that monitors the blood pressure and the coronary flow. Most of the time will be flowing around 750, 800 cc's per hour on the coronary flow. And then it has batteries. But it is safer, of course, to get it plugged, to have the batteries always as a, backup, so you don't want to get in trouble. But so it is, if you ask me, I mean, sometimes we have a little bit of problems in the planes to put it in. So, probably, hopefully in the future versions will be a little bit smaller. So it's a little bit easier to handle. But so far, we don't have any other portable device, not even, I think, clinical trials or FDA approved. And so that's what we're using. And it's, it has all these capabilities. It's very nice. Probably I like to say that other thing that it makes it a little bit difficult to use the device is that we would like to perfuse the heart, obviously, with blood. And then that is a little bit of a limitation, because when you do the donor, essentially what we do is we put a cannula in the right atrium. And at the time, right before cross clamp, we drain the blood of the donor to use it on the circuit. You have to remember that this is kind of an ECMO, a portable ECMO circuit for the heart. So in that period that we have to drain the blood of the donor, all the other organs that are getting procured on the same donor, they get a little bit nervous, because the blood pressure goes down, obviously, because we sort of goes down the obviously the preload of the heart and the blood pressure. But it's a very short period of time. You could get the blood normally in 1 to 2 minutes, and then all the organs can get flushed for transplantation.
Yeah, fascinating. While the heart is in the machine, in the OCS machine, are there any therapies that can be applied?
Well, there has been in heart. I'm not that aware. Maybe some experimental work. I'm very aware in lung, that while the heart is getting perfused, that there's some group of investigators that have applied, for example, UV light to get rid of hepatitis C virus. So for example, we have to understand that there's around 20% of our donors are from a drug overdose, and from those 20%, they have hepatitis C. So now what we do is that we treat the recipient, with antiviral to get rid of the hepatitis C donor. But it has demonstrated that also if you could perfuse an organ, on ex vivo perfusion, and then use UV light, you could get rid more virus. So you could kind of decrease the viral load before implantation on the recipient. So I can imagine that there are several therapies that we would like to have, but we haven't gotten to the point really, particularly in lung. I think I like to see, for lungs with pneumonia, for example, that you would be able to be perfused for a long period of time with antibiotics, and then probably recover the pneumonia. But the time so far is not enough, but it has potential. So we need to understand better what produces the edema in the tissues, because this is something that, it gets produced in the lung and the heart with a long perfusion. So we can figure out that probably we be able to have longer perfusions, more therapies, and probably more elective transplants.
Absolutely remarkable that what had been a limitation, just the transport, stands to potentially become a therapeutic window where infections may be eradicated before an organ is donated. Really, conceptually, that's just a remarkable thing. Are there any special advantages for the kinds of patients that we often see at Mayo Clinic?
I think one of the most things that can have a greatest impact, I think there's multiple, so we could talk a little bit extensive about this. Sorry about this, if it's my passage, I could get very long. I've been talking about
It's fascinating.
And then, one is the DCD donors. So can everybody can understand, because our traditional way, as we were talking about the cold storage, the traditional donors have been the donors after brain dead. The brain dead, the donors legally dead, and we could take the heart. But there's many donors that they have had neurological injury, and what happens is there's no future, and the family decides to withdraw the care. So essentially, there's a planned withdrawal of care, and then that most of the time will happen in the operating room. And then withdrawal care happens, palliative care is started, and normally what happens is the blood pressure gets low, saturation gets low. There's a period of cardiac arrest of 5 minutes, and after 5 minutes, you could declare death. So as separate from the transplant team, death is declared, and then you could go in and you will open the donor, but the heart will be stopped and will be distended and will look terrible. And we don't want that for transplantation. So what we do is that this was pioneered in Australia, and then come back to Europe and now to the US. And then we take the heart and put it on the Exvivo heart device. And we resuscitate essentially the heart. So you will see in those hearts that they have very high lactate, to start. And then as, the heart starts beating and then gets better, lactate is stabilized and, decreases, and we could do that heart transplant. So there has been already a trial in the US comparing using these hearts versus just using cold storage, and the survival has been the same. I think that's what was the data that was presented in the ICHLT shows. Survival is the same, DCD versus brain dead donors, recover with Exvivo heart perfusion. So same survival. And then there's a little bit more of primary graft dysfunction. So you put the heart on it, then you do the transplant. And there's more dysfunction of the heart at the beginning. So you have to be quite comfortable on doing ECMO for a couple of days. And then it usually quickly goes away, because we normally take, young, strong hearts, and then they get better. So we have done around, for example, this year, 7 DCD heart transplants here at Mayo. So, and it continues to grow in our region. The live source, around 30% of the donors are DCDs. So it's a very important source, for heart transplantation.
And by the way, just to clarify for listeners, DCD stands for donor after cardiac death, as opposed to donor after brain death, right?
Well, we have tweaked it a little bit what it stands for, because we call it donor after circulatory death. Because, we think about the cardiac death as an irreversible thing. In this case, circulation has been stopped, but we could recover the heart, transplant it successfully, and then have good function. So it has been changed a little bit to donors after circulatory death. So that's what it makes good
sense. I have maybe one more question for you, and that is, these capabilities to travel with the heart 8 hours, potentially longer, in essence, they stand to limit geographic boundaries of where donors and recipients are, and could fundamentally change organ distribution rules. Do you see a change in transplantation on that basis in terms of how organs are distributed, the UNOS rules? Do you think there'll be a modification coming from this technological advance?
Well, the allocation for heart transplantation has been modified recently, so we're a little bit getting adjusted at this point. But certainly what it happens, it has prioritized urgency. So for example, you have somebody on ECMO, you will be status 1. You have you're supported on an Impella, you'll be status 2. And then it comes down, you have an assist device, that you'll be status 4. So, and then you could take, first the hearts get offered to, 500 nautical miles. So, a good range. That's quite a long range. So I haven't seen any sort of discussions about this, about getting broader, but what happens is that, we have gone all over the country. We have gone to New Mexico, to Florida, South Carolina, here from Mayo Clinic, Rochester, to northern New York, and that's the beauty of the thing. And then we don't have to get in an urgency, to sew the heart in. So it's quite remarkable. So it might happen later on when it gets more widespread use, but I don't think I've seen something happening these days. Yeah.
Well, Dr. Villavicencio, absolutely fascinating discussion. Thank you for joining me. It's remarkable to see the advances that you and your colleagues have been bringing to this space that continue to evolve. And thank you for sharing some of that with us today.
Well, thanks very much for the invite, and look forward to see you all, in the cardiology side working. Thank you.
Thank you.